because as many of you probably have heard me say, I am definitely postmenopausal, and it's been a very rough time of it. And this, if I was a waitress, which I may be at some point in the next year or so, if this contract doesn't get extended, then this is how I would feel. This is how I feel if I was a waitress and you came and you're like, oh, but can I have like light this and heavy that? I'd be like, seriously? You know I make minimum wage, right? You know I am postmenopausal or right in the middle of going through menopause. Take your black coffee and then you will hear. By the nature of the way I said that, you'd be like, okay, that'd be great. That'd be great. All right. But some patients that you'll talk to really don't have any significant issue with menopause. And so I talked to many of my female family members and I asked them, in probably a nice, not so polite way, I said, why didn't you tell me about this menopause? Why didn't you explain to me how terrible it was? And they're like, what are you talking about? I'm like, so I went through menopause at 49. In the first 3 years, I had hot flashes all day, all night, every hour. 150, 250, 350, 450, all day, all night, all day, night. For 3 years, and I mentioned that to them. They're like, oh, I never had any of that stuff. Like I had a little bit of hot flashes for 6 or 12 months, and that was it. I'm like, oh no, like I am like 3 years into this and still terrible hot flashes. So some patients that you talk to are not going to have any issues. The problem is we as healthcare providers don't do a good job in preparing our patients for the changes, even if they don't have significant changes or changes that last for a long period of time. We still need to talk to our patients as they come closer and closer to their perimenopausal period, menopausal transition, and into menopause. So we're going to talk about some signs and symptoms that these patients may have and how we can help our patients through this. We got our TLOs and our ELOs. Just a quick review from last week. Hearing. Where are you? Oh, yeah, that's why I can't see you. Way back there. Okay. 29-year-old female comes in, painful menstrual cycles, painful intercourse. She was seen about a year ago for these symptoms. You, as a astute provider you are, said, oh, I'm going to put you on some medicine. So you gave her ibuprofen, which is possibly an inhibitor, 800 milligrams 3 times a day. Is that a good dose? Did you do good? Yeah, did pretty good. We hope that she hadn't had to take that for the whole year. That's pretty rough on the belly. But nonetheless, she said she's been taking consistently and a contraceptive. And a year later, she comes back and says, well, I'm not really much better. You did a transvaginal ultrasound, completely normal. Nothing remarkable on that transvaginal ultrasound. What do you think the next step is for the management or evaluation of this patient? Referral. That's the best answer. And the reason is because we don't know what this patient has. We were assuming, here you go, sir. We were assuming based on her signs and symptoms, with a couple of the D's in there, of course we probably want to get a little bit better history as well. But based on that, we assumed she may have something like endometriosis. And we said, well, let's put you on some medication, see how you do. She doesn't do any better. We don't really know if that is the diagnosis. So remember, we've got differential diagnoses in there as well. We've done the ultrasound. The ultrasound helps us rule out some of those differentials. But if we don't see anything, the pain continues, it's already been a year, then it's time to refer the patient. Right? Because otherwise you can put them on GnRH therapy with GnRH treatment with advanced therapy if we know what the diagnosis is. So here we don't even know what the diagnosis is. Replacing the combined oral contraceptives with an IUD, you're doing the same treatment, right? We're still doing the same thing. We're giving them progesterone, combined oral contraceptives, of course, estrogen and progesterone, or we do progesterone only, but those are using the same form of treatment for this same issue, so that's not going to be beneficial. And then hydrocodone. Hydrocodone is addictive, it's a narcotic, it's not something we want to do routinely. And so you'll be in a position that the majority of the time, very rarely will you prescribe opiates to folks. Right? And that's just because of the high risk of addiction that we have seen. If you do happen to prescribe opiates to somebody, what is the very next prescription you're writing for? Narcan. And it doesn't matter if you give them 5 hydrocodone or 5 opiates, or you give them 105. Every single time, the recommendation, even by the DOD, is that we give Narcan. And that is protective of the patient and really quite protective of you as well. Because even if we don't do that routinely in the DOD, okay, these patients still have the likelihood of coming back and suing you or their parents do or their family members do if there is a poor outcome. So I would just have that on your list that if I'm going to prescribe narcotics, then I'm going to do nothing. And this is fairly recent in the DOD. All pain management folks do it. It's probably, I've seen the change in the last year and a half. Where on the outside, it started about 10 years ago. So we're quite a bit behind than our civilian counterparts. So we're going to refer for a diagnostic lab. All right, terminology that's associated with menopause. We have menopause itself. Now, menopause is that time that marks the end of the last menstrual cycle. It's not really the end of that last menstrual cycle, but it's a year after that. So you cannot have had a menstrual cycle for 1 year and then they're considered to be menopause, or in the menopause or postmenopausal stage. The average time period for menopause, for women to go through menopause, is about 51 and a half age. And really, this occurs as a natural process the majority of the time, where we have attrition or decrease in follicular function. The follicles in the ovaries, they've kind of been worn out over the reproductive time period, and they really are not functioning well. So if they're not functioning well, they're not releasing FSH, not releasing not releasing estrogen and progesterone, which then we don't have any release or have increase in release of FSH, LH. Okay? So that is a menopause. So 1 year without a menstrual cycle, then someone is considered in menopause or postmenopausal. We have time period leading up to that, and that's the menopausal transition or the menopausal, perimenopausal time period. And really these start at the same time, but they end a little bit differently. The menopausal transition, that is going to end when the day of the last menstrual period, and our perimenopausal, that continues through the time of the beginning of menopause. Okay? Average age for patients to start going through this menopausal transition or perimenopausal time period is about 47. So we have 47 for the onset of symptoms, and about 51 and a half or so that marks the beginning of menopause. And patients going through this menopausal transition, this perimenopausal period, that tends to be the most symptomatic. And that's usually when they're going to come in to see you to say, I want to know if I'm going through menopause or what's going on because I'm feeling all these changes that are occurring in my body. We have the postmenopausal years, and that's the years after the final menstrual period. So we've got our final menstrual period. A year later, we're considered menopause, and from then on, the patient is called postmenopausal. So when they come in, you'll say, hello, my name is PA so-and-so, are you Miss Postmenopausal? No. That's what they say. Oh, she's postmenopausal. That becomes your name, postmenopausal, right? And then we also have something that's interesting, something called primary ovarian insufficiency. And primary ovarian insufficiency is there's something going on at the ovaries, but it's occurring earlier than we expect. So we have patients that are less than 40 years old, and they're having these menopausal or perimenopausal signs and symptoms. They're having the hot flashes, they're having the decrease in the estrogen, they're having the skin changes, but that's way too early. So, realistically, if you're starting having those symptoms 40 years and younger, there's oftentimes some other cause. There's still people that are having children in their early 40s and mid and late 40s. So these patients, we don't want to just say that they are menopause and going through menopause if they're less than 40 years old. There's something else that's causing those ovarian follicles not to work correctly. And it could be things like chemotherapy or radiation, so kind of secondary causes that are pushing these patients into an early menopause. on a timeline, this is what it looks like. So we have our early time period where we have our reproductive time period. Here, we have regular menstrual cycles as we get to the peak of that reproductive time period, normal FSH, but as we get towards our menopausal transition, our perimenopause, we're gonna start seeing an increase in the FSH, an increase in the follicle stimulating hormone. Remember again, our estrogen and progesterone levels are decreasing. And so we don't have the appropriate negative feedback, and so what is the pituitary going to do? It's bombarding the ovaries to make estrogen and progesterone, but there's not enough follicles to make the estrogen and progesterone. So we're going to start seeing an increase in FSH, and then we've got our menopausal transition that ends at the last menstrual period, where perimenopause goes all the way through that whole year, and that ends as that female begins the menopause, going into menopause. We have early menopause, that's considered early menopause is the first 4 years of menopause, and then we have late menopause, which is after that first 4 years. Again, it's an increase in FSH here, and then increase in FSH. What we're gonna see, those physiologic changes that we see surrounding menopause, so the perimenopausal time period, or menopausal transition, we're gonna start seeing the changes in the menstrual cycle. And oftentimes, these patients are gonna have mixed anovulatory and ovulatory cycles. So they may have 2 or 3 months where they have regular menstrual cycles every 28 days, and then they'll skip a menstrual cycle for 2 or 3 months, and then they'll have one, and then 3 weeks later have another one, so they're starting to get these mix of anovulatory and ovulatory cycles. The good thing is that these patients, or maybe the bad thing is, potentially these patients could get pregnant in their late 40s, not typically very good, but the good thing is no one's been pregnant, of course, according to the Guinness Book of World Records, greater than 55. So 55 years old. Matter of fact, I was reading an article the other day that said lady was 59 and just had a baby. I'm like, that's not true. The article told me that. I'm sure it was like probably on Instagram. I'm not even on Instagram, but it's not true. At 59, I have a baby. And then when they go through these differences or the variations in their menstrual cycle, that's again what's going to prompt them to come and see you. So oftentimes we don't need to do this big workup. Are you in fact going through menopause or perimenopause or menopausal transition? Just based on their age and their signs and symptoms, you can say, yeah, it really sounds like you are going or approaching menopause. Right? If we do blood work on these patients, we're looking for that high FSH, usually a higher than normal LH, and then decreasing estrogen and progesterone. And postmenopausal FSH is very high, so normal is about 5 to 10. We're talking about levels greater than 40 for postmenopausal. There's other physiologic changes that we're going to see in addition to those menstrual cycle changes. So cardiovascular disease. Cardiovascular disease is a huge leading cause of death in women over the age of 50. We consider estrogen protective, and if we no longer have that estrogen that's protecting our cardiovascular status, that's when we see that increased risk in those older patients. So 50, 51, 51 and a half, as those estrogen levels significantly decline around that time of menopause. What estrogen does to help be cardioprotective increases our HDL and then ultimately lowers cholesterol. So we think of these patients around 50 or so as having increased risk, and then around the age of 70, their risk actually equals out. So I think what happens is the body almost gets used to not having this estrogen. It's a pretty big slap in the face initially when these estrogen levels are declining. But around the age of 70, the body's used to it. Our cardiovascular risk equals out with males. Postmenopausal weight gain, it's a huge thing. Usually around the lower abdomen, the hip area, we have this big preponderance of fat distribution. And so we talk to our patients before they go through menopause, before even they go through the perimenopausal time period, about how to potentially mitigate this weight gain by increasing their exercise, maybe talking about dietary changes as well. We have a lot of dermatologic changes that can occur. We have these hyperpigmented age spots, people call them. We have loss of elasticity, decreased blood supply as well. So these patients, when they injure, have a small, maybe a small tear in their skin. They don't tend to heal up as well because we don't have that estrogen and that increased blood supply in those affected areas. Even dental changes occur. So I didn't realize this until I went through menopause, but you actually get a decreased amount of saliva in your mouth. Okay? You constantly have this bad taste in your mouth, and that's again due to estrogen, lack of estrogen. Ultimately increases the risk of dental caries, increases the risk of tooth loss as well. So we talk to our patients about routinely getting their dental exams, routinely getting your cleaning and your dental exam. So TRICARE will pay for cleaning twice a year, and then some policies will pay for it every 3 months. We just make sure we talk to our patients about that. CNS changes occur, those hot flashes are occurring day and night, so patients are not sleeping well. They often have an increased risk of developing sleep disorder breathing, which is also called sleep apnea. So sleep apnea, where they didn't have it before, now they have it. And then again, if they are sleeping, their sleep quality is typically pretty poor because they're waking up every hour with these hot flashes. So you get really hot at night, and then you get really cold, so covers on, covers off. Well, the spouse is probably not sleeping very well either because covers on, covers off. I know in my bedroom, I specifically had a split unit put in, so at night that thing is set at 62. 62. Because if it's not 62, I'm up half the night. Like seriously, it's terrible. So because they're not sleeping well, increased risk of fatigue in general, increased risk of depression. And females have a 1.5 times higher risk of depression than males of the same age. Okay, we have loss of tissue density in the breast, and that's replaced with adipose tissue. And that becomes important when we talk about imaging for breast issues. So women under the age of 30 get certain imaging for if they have breast complaints. Women over the age of 30 get a different type of imaging for breast complaints. And then skeletal, but we have loss of bone mass density. Loss of bone mass density increases the risk of not only osteopenia, but osteoporosis, and increases these patients' risk of hip and vertebral fractures as well. There is something that really affects a good portion of these patients, and that is called genital urinary syndrome of menopause. It used to be called atrophic vaginitis. So about 40% of women are going to be affected by this, and what their main symptom is vulvovaginal irritation, vulvovaginal dryness. It's affecting their ability to have intercourse with their partner because it's so painful, because it causes atrophy of the vaginal tissue as well. These patients may complain of kind of this clear or blood tinge discharge. Oftentimes the blood tinge is because of the skin is so atrophied and so thin. Anytime they have some irritation, they may have to do some scratching that causes pretty significant excoriation of the skin. Oftentimes these patients are going to have significant dyspareunia. Again, this is something we talk to our patients about before they go through this. These are things that they can expect, and how can they mitigate these complications? How can they mitigate the discomfort with intercourse? And they can mitigate it by having frequent intercourse even before they go through menopause. The problem with these genital urinary symptoms of menopause, they don't typically get better. They typically need to have intervention. They need to be treated. Okay? So it's diagnosed really by physical exam. We have this friable means very red and irritated vaginal epithelium. Remember, the vagina, the tissue that it's made of is medial to the heart line. So that's non-keratinized material, so it doesn't have a lot of, what's the word I'm thinking of? Menopause. Lubrication measures, okay? And so we do on the exam, we can diagnose this by doing an exam, a physical exam, looking externally at the tissue, and you'll notice it's very pale, very thin, and again, you might even see excoriation. On the pap smears, on the cervical cytology, you may see something called parabasal cells, and that is specifically indication of the genital urinary syndrome of menopause or atrophic vaginitis. So treatment, again, we talk to our patients about regular intercourse before they go through menopause. The literature says once a week is typically what's recommended, so that way the vaginal tissue doesn't become more and more atrophic. Okay? The vaginal introitus itself can also become very stenotic, and by having regular intercourse, it reduces the stenosis and the scarring that we're going to have. Talk to our patients about the measures that they can use over the counter, like lubrication measures. We also can recommend for these patients to have topical estrogen, and they can use that in the form of topical estrogen cream. We could use ring, we could use pessary. Now, of course, you've got to make sure that they have no risk factors for taking estrogen, but the topical estrogen cream can be used without opposing progesterone in patients that have a uterus for up to a year. So always remember, patients that have a uterus, we wouldn't want to give them unopposed estrogen, but you can do that in a topical form without having to give them progesterone. Usually, they can do that once daily for the first couple of weeks, and then usually twice a week is pretty appropriate therapy. And then we have these other symptoms these patients may have. Okay, because FSH plays a big role in this, we can use this mnemonic visual. Flashes, flushes, forgetfulness is pretty common in menopause. These patients tend to have increase in depression. They're going to start having those sweats, increased risk of stroke, especially in that early portion of menopause. They can have headaches, increased risk of heart disease with that cardiovascular risk, insomnia, urinary symptoms. I point out urinary symptoms because these patients will come in to see you time and time again because they're having frequent urination. Even oftentimes frequent urinary tract infections, okay, where they never had urinary tract infections now, never had urinary tract infections before, now they're having them all the time. It's usually because we have that change in the vaginal tissue, that we no longer have, like the vaginal pH has changed, and we don't have that protective measure from the vaginal pH. So if we talk to these patients early on and we can get them on a topical estrogen, and we often can reduce their incidence of the frequent urinary tract infections. Even from the emergency department, I've talked to many patients about topical estrogen, and I've placed them on topical estrogen because they keep having these frequent urinary tract infections. They've seen the specialist, and no one for years has put them on topical estrogen. It's at least worth trying, right? It's not going to harm them, okay? But we don't want to use it for more than a year without progesterone. So vasomotor symptoms, those are typically what's going to bring your patient in as well. Those are the hot flashes, the flushes, the cold sweats that they're going to have at night. And really, it is a problem with the thermoregulatory system that has changed. Okay, prior to this time period, we don't have a problem, but really at the level of the hypothalamus is where we start to have an issue, or we have that we no longer have that protection or that thermoregulatory system that's working appropriately, and it's usually caused by estrogen withdrawal. Okay? So these hot flashes, these patients are going through estrogen withdrawal, which is why they have the majority of their symptoms earlier on in that menopausal transition or the perimenopausal time period. They're going to typically have these recurrent flashes, hot flashes or flushing, and usually it lasts every couple of minutes. We have there's increase in skin temperature, so if you touch somebody that's going through hot flashes, most of the time you can look at them and they're just sweating, and they just out of nowhere they start this profuse sweating, but if they're not sweating, when you touch their skin itself is hot, but there's actually no increase in core temperature, so you wouldn't find an increase in core temperature. It's often associated with a slight increase in blood pressure and slight increase in heart rate and respiratory rate. Some people will say that when they start having these hot flashes, it's almost like they're having an anxiety attack. Okay, that lasts for a couple of minutes. I know that happened to me as well. Like I just had this severe anxiety that's associated with these hot flashes that occur. And the issue is when you talk to your patients about this, the reality is they can last for 15 to 20 years. I wouldn't put that out there at the beginning. When patients come to talk to you about how terrible these things are, I wouldn't be like, oh, you just started. You got 15 or 20 more years. But I wouldn't do that. I probably would not have that conversation. I'd be like, well, let's see how we can address this and hopefully, this won't last very long. You know, those are the kind of words like, let's see, but they certainly can be. So how do we diagnose menopause? So again, these patients are gonna start having these changes in their menstrual cycles. Okay? When they have their last menstrual cycle, we're gonna wait for a year after that last menstrual cycle. Here's what's gonna happen. They're gonna think they're going through menopause. They didn't have a menstrual cycle for 3 or 4 or 5 months, and then all of a sudden they have a menstrual cycle. Guess what? Their timeline just started over again. And while they're having these mixed menstrual cycles where their variability, they're also having these hot flashes. So they're having a variety of things. And when you tell them that your timeline just started over, that's also a little frustrating for these patients. So we're going to talk to them and get a history on them. Are you having hot flashes? Are you having flushes? Any problem with weight gain? Any problem with vaginal irritation or vaginal dryness? Those are all signs and symptoms that yes, they are going through menopause. Now, if they are less than 40 years old, again, we're not going to diagnose these patients as menopausal transition or perimenopause or menopause, because that's too young. They're too early. We want to try to figure out why, in fact, are they having these signs and symptoms as if they were in their late 40s. So these patients need a workup. They need labs. Check their TSH, check their FSH, LH. Make sure you get a good history on them and a good family history as well. If they're 40 to 45, maybe this is early menopause. Still consider getting some labs on those patients. Okay? Make sure you have a good differential for these patients. And then if those labs are all normal, then they can continue on and say, yeah, you probably just went through menopause a little bit early. Okay. Greater than 45, they don't need a big workup. There's nothing that we can do to prevent this from happening. It's going to happen. Now, if I was you and you happen to see a question about someone less than 40 who said, my mama went through menopause early, my grandma went through menopause early, don't choose menopause. Don't choose menopause because just because their parents or their grandparents were diagnosed, okay, doesn't mean that was the correct diagnosis. You got to think for yourself and say, I just told you that if it's less than 40, that's not the correct diagnosis. There's something else that's causing it. Now, it could be that it was induced by a medication that they were on, but the answer is that they are premature ovarian failure. Like something has caused those ovaries to fail earlier than what we would expect. And again, our differential. Pregnancy can cause the exact same signs and symptoms. So let's make sure these patients have mixed anovulatory and ovulatory cycles. We're going to do an HCG on them. Thyroid problems will cause these same signs and symptoms as well. Hyperprolactinemia, and that's why prolactin's in your labs, TSH is in your labs. Look at the medications that they're on. Maybe it's the medications. Especially patients that have a known history of thyroid problems, their thyroid medication may be overactive or underactive, so you want to make sure you check that. Malignancy, pheochromocytoma. Now, pheochromocytoma is pretty rare. I've seen 3 ever in my 30 plus years, but it's not impossible. Okay? So make sure you have a differential for these patients that are coming in, and just because they have a family history of someone going through menopause early doesn't mean that that's what's going on with them. So what can we do for these patients? How can we help these patients through this time period? Well, we can do estrogen therapy. We can do just estrogen therapy if they've had a hysterectomy. We could do local estrogen therapy with that topical estrogen cream, especially if they're having significant genital urinary symptoms. Or we could do combined estrogen progesterone therapy in patients that still have a uterus, so if they're not post-hysterectomy. And remember, we have to add that progesterone because you give somebody estrogen therapy only, it thickens the lining of the uterus, it increases their risk for endometrial cancer, so you don't want to do that. Our primary goal, though, for hormone replacement therapy is to treat the vasomotor symptoms. Treat the vasomotor symptoms. That's it. It's not cardiovascular risk reduction. It is not genital urinary symptom reduction. It's not helping with their weight gain. It's only if they come to you and say, these hot flashes are out of control. Now, in the last probably 5 years, there's been a lot of research on this hormone replacement therapy. The problem is, and the reason why I don't bring to you all the outcome of the new research, is because it has not been bought off by OBGYN. Okay, so OBGYN has chosen to stay out of the conversation, and this conversation, this research has been done by this menopause society. So we don't have the backing of our consultants, and so what I'm bringing to you is the stuff that the OBGYN, our colleagues, that they agree with. Okay, but we use this only for vasomotor symptoms. And it is recommended, if we are going to put somebody on hormone replacement therapy, we do that within 10 years of the beginning of menopause, okay, and before the age of 60. So someone comes in, we diagnose them with menopause at 50. Okay, we have 10 years, up until the age of 60, to start this hormone replacement therapy. If they come in, we diagnose them with menopause at 55. We only have 5 years. Okay, so we have 10 years, but it needs to be under the age of 60. If we don't do that, if we don't start this early on, it actually increases our risk of cardiovascular disease. Okay? So if we can start it within that 10 years, under the age of 60, we have that decreased risk of cardiovascular disease. But again, American College of Gynecology says we're not using it for that. We may get that secondary benefit, but what we're using it for is improvement of vasomotor symptoms. Other secondary benefits, it increases bone density, so it decreases our risk of osteoporosis, decreases our risk of fragility fracture. It actually decreases the risk of colorectal cancer as well. So there are benefits, but we're going to go with vasomotor symptoms only for our benefit. Okay? And there are risks. You want to make sure before you even talk to your patients about going on these medications or how you really consider these patients going on hormone replacement therapy, make sure we don't have a history of stroke or PEs or DVTs, because these medications, hormone replacement therapy, especially if you have estrogen, increases the risk of stroke, increases the risk of DVTs or pulmonary embolism. Okay? Again, increased risk of cardiovascular disease if we started after the age of 60. And then breast cancer, if you're using the estrogen progesterone therapy, it seems beyond 3 to 5 years, it seems to increase the risk of breast cancer. For some reason, which is kind of weird in the literature, doesn't really understand this, but if we use estrogen alone, so patients that have had a hysterectomy, we use estrogen alone, we don't seem to have that increased risk. So we can sometimes use that estrogen alone beyond 5 years without an increased risk of breast cancer. And we want to make sure we talk to our females about what is their main issue and what ultimately is our priority in the management of their main issue. If their main issue is these hot flushes, then we can talk about hormone replacement therapy as long as they don't have significant risk factors. When we provide treatment for these vasomotor symptoms, we can do this in a cyclic fashion, okay, or we can do it in a non-cyclic fashion. Cyclic fashion, and someone has an intact uterus and they have not had a hysterectomy. We usually do daily estrogen plus that progesterone, but the progesterone is typically cyclic. Okay, so we can see here, we do it for 12 days on, usually the first 12 days. If they've had a hysterectomy, one of the most recommended forms of estrogen for these patients is the transdermal estrogen. And the reason why they say transdermal estrogen is because transdermal estrogen is not metabolized by the liver. Okay? So it does not increase, or at least based on the literature, does not appear to increase the risk of DVTs and PEs in these patients, which also doesn't increase the risk of stroke. The other thing is that patients that have a history of liver disease really shouldn't take estrogen, but if they use a transdermal because it's not metabolized by the liver, these patients can typically do just fine. When we put these patients on this estrogen progesterone therapy, it is not uncommon once they stop the progesterone for them to have withdrawal bleeding. Believe me, if they're 55 or 60 and they're starting to have vaginal bleeding, they're going to come and see you about it. So just be aware that it's not uncommon for them to have some postmenopause, or for them to have some bleeding afterwards. Okay, the continuous estrogen progesterone, again, if they have a uterus, we're gonna put them on, you can do either oral estrogen or you can do the transdermal. You don't have to worry about the dosage in here, okay? Plus, we've gotta give them that progesterone. So we can talk to our patients and it doesn't really matter if they wanna do cyclic or continuous, right? If they've had a hysterectomy, we can do the oral estrogen or we can do the transdermal. Again, transdermal is what is preferred, at least nowadays. We never want to give unopposed estrogen to a patient with a uterus. So anytime we're talking to patients that have not had a hysterectomy, we talk to them not only about the estrogen component, but we got to bring that progesterone component as well, whether it's continuous or cyclic. So hormone replacement therapy, typically we recommend about 5 years and often not beyond 60. Okay? Unfortunately, those vasomotor symptoms, as we talked about, can persist for up to 20 years or so. And so according to the American College of Gynecology, they have said, look, we can consider using this hormone replacement therapy in patients beyond the age of 60 for those vasomotor symptoms, as long as they're doing fine on the medication and they don't have risk factors for stroke, for cardiovascular disease, and for thromboembolic disease as well. Okay. So we've talked to our patients about it. Sometimes what they recommend is when we stop the medication, so if the patients go off the medication, do we taper off the medications? If we taper off the medications, they're a lot less likely to have a rebound of those vasomotor symptoms, so that is a consideration. So if you put them back on there, start them at the lowest dose after they're going on beyond 5 years, or they came off of it and now they need to go back on, you start them at the lower dose, and then get them off as soon as possible, and then usually a taper fashion. Treatment considerations, oral estrogens, because they're metabolized by the liver. So if they have a history of high triglycerides, if they have gallbladder disease, they have known thrombophilia, if they have known liver disease, those patients shouldn't be taking estrogen therapy. Okay? Transdermal patch is preferred for patients that have migraines with aura. And that's even on the contraceptive sheet that I'll give you for your exam. But in general, most of the literature nowadays is pointing towards the transdermal estrogen patch in general for these patients. Okay? Contraindications, if they have a history of breast cancer, history of coronary artery disease, if they have thromboembolic events in the past, unexplained vaginal bleeding. Once you figure out why they have vaginal bleeding, then maybe you can put them on hormone replacement therapy. But if they have unexplained vaginal bleeding, you don't want to give them estrogen, okay, and they end up having endometrial cancer as a cause of their vaginal bleeding. So you've got to identify the cause of that first. Or if they have a high risk of endometrial cancer, so years of unopposed estrogen. There are other medications that are available out there. We have this SERM, so basidoxine with estrogen combined. And with this medication, it helps treat the vasomotor symptoms, okay? But it does not seem to cause any increase in risk of breast cancer. So it doesn't seem to affect the breast tissue at all. These patients don't typically have change in their breast density or discomfort in their breasts associated with that estrogen. If patients have a history of depression or are complaining about concerned about some depressive symptoms, you can put them on hormone replacement therapy and an antidepressant, or sometimes those antidepressants can work as non-hormonal agents and help with the vasomotor symptoms. So SSRIs, SNRIs, they work pretty well in the majority of patients for the hot flashes, for the vasomotor symptoms. Gabapentin works very well for hot flashes as well. And sometimes patients just need to take these medications at night. They don't necessarily need to take them all day. Clonidine, we can use, but clonidine, the thing about clonidine, you guys know about clonidine in farm? So clonidine is an antihypertensive. The problem with clonidine is it can really lower someone's blood pressure. It's kind of erratic absorption of clonidine. The transdermal is a little bit better than the oral, but just kind of be wary with clonidine because those patients can get pretty hypotensive, especially when they go from sitting to standing. You can get that vasovagal response. And then pregabalin, Lyrica, that can be used as well. Lyrica, pregabalin tends to have a decent amount of side effects, so some people can't tolerate that. What I have seen the most, I would take gabapentin, it works great, but venlafaxine is one of the more common SNRIs that are prescribed for hot flashes. And then Veozah. So there's this really funny commercial that is out there, and this lady, she has a microphone, she goes to people on the street, she's like, let me ask you a question, what do you think about VMS? The lady's like, is that like a new pop band? And then another lady is like, she's like, oh, I don't even know what that is. She said, what if I told you it's due to menopause? And it's called, and she's like, very much sweaty? Like it's such a funny, it's very funny to me. I'm like, that is so true. But anyway, it's about, they talk about a couple of, it's for one of these newer medications that they have. And although something like Veozah is not on formulary, if these patients have tried like an SNRI or they tried the gabapentin, they're still not, their symptoms still aren't controlled, or vasomotor symptoms aren't controlled, you can just submit to pharmacy for a special request for the medication, and there you get it. Chickpeas, lentils, soybeans, they have isoflavones, and some people will get relief of their vasomotor symptoms with the isoflavones. Black cohosh is another thing that's been around for many, many, many years. And before we had these other non-hormonal agents, black cohosh was used by many folks, and I think it does an okay job. We do have topical progesterones out there now. Some people use melatonin to help them sleep better at night, and that sometimes helps them with their hot flashes. And then we want to think about this kind of holistically. So talk to our patients about their cardiovascular risk, blood pressure control, lipid control, smoking cessation. Alcohol tends to increase vasomotor symptoms, so limiting their alcohol use. And then weight, maybe not necessarily weight loss, but definitely weight control as they're leading up to their perimenopausal time period. Yoga, meditation can often help these patients, just again, thinking about it more holistically. And then routine exercise, not necessarily pounding the pavement running, but just some sort of regular exercise. As a matter of fact, to help reduce their osteoporosis risk, things like weightlifting tends to help strengthen the bones, so we can talk to them about that. Dress in layers, so that they're prepared when these hot flashes occur, and then have them put a split unit into the bedroom instead of the 62, and that tends to help pretty well. Okay. For that sexual discomfort, that these patients oftentimes are going to come and talk to you about that as well, because being able to have intercourse with your partner is pretty important for most people. So when we talk to them about the over-the-counter measures, and then early on, don't let them wait for a year or two. Talk to them early on. This doesn't work in the next, 2 to 3 months. Come back and see me. Maybe we'll put you on some topical estrogen if that's something that they're interested in. Tobacco use, excess alcohol. Talk to them about that, and then supplementation. Supplementation. Oftentimes we recommend calcium or vitamin D supplementation for women, and now even for men. But for women starting in their 30s, they really should be on some sort of calcium or vitamin D supplementation, and then engaging in regular activity as well. All right, so let's go on to our osteoporosis. Now this is kind of just a real quick lecture on osteoporosis, because I think in ortho you guys had a pretty decent lecture on osteoporosis. So after menopause, we know we have that decrease in our estrogen levels. And what happens is the regulatory effect of bone reabsorption is lost. So when you have this accelerated bone reabsorption, you do not have balanced reformation. And if you don't have balanced reformation, it increases these patients' risk of not only osteoporosis, but first osteopenia. So osteopenia is going to be more that weakening of our bones, that decrease in that bone mass density. And then if osteopenia is not appropriately managed, it increases our risk of osteoporosis. Osteoporosis is significant weakening in the bones, and ultimately increases these patients' risk of fractures as well. We have primary osteoporosis, and that occurs as a part of aging and that postmenopausal time period with a decrease in estrogen. And then we have secondary osteoporosis. That is usually something that either we have done or the patient has done that caused the osteoporosis. So most of the time, it's risk factors like smoking, being very thin, or medications that the patient is on. Sometimes we have a patient that comes in and they have a fracture of their vertebrae or fracture of their hip or femoral neck, or even they fell from standing, they fractured their wrist. We consider that something called a fragility fracture, because most people should be able to fall. If you fell right now, you were walking, you fell, you wouldn't break a hip. Okay? But patients that fall from standing and break a hip or break their back, break a vertebrae, we consider that fragility fracture. And that is an indication that they have osteoporosis. Okay, I've seen women literally take their bra off, and they took their bra off and they broke their back. They broke a vertebrae in their back. Okay? So it's not something that it's not something you will not see. And anytime these patients have a fracture, increases their risk or the morbidity and mortality. You have an 85-year-old comes in, they have a hip fracture, they are not likely to live very long after that. We want to make sure that we reduce their chance of falling and reduce their chance of osteoporosis. So again, secondary osteoporosis is not typically related specifically to a decrease in estrogen. So we think about these risk factors that are causative of secondary osteoporosis. Things like steroids, chronic steroid use like COPD patients, or maybe people have rheumatoid arthritis or something, thyroid problems. They're very thin, so overweight doesn't tend to increase it. Early menopause, if they have kidney or chronic liver issues, and then also think about their family history. So shattered, and then family is our family history. These are all the risk factors. What's not on here? Degenerative joint disease. If someone has degenerative joint disease, does that increase the risk for osteoporosis? No, that causes back pain. Okay, and the thing is that most people that have back pain, they're like, oh, I think I have osteoporosis because I have back pain. No, it's not related to that at all. Right? Most people have no idea they have osteoporosis, right? Until they fall and they break something with a fall from standing, and they're like, oh, that's kind of weird that I broke something, I just fell from standing or while I was walking. So people often misconstrue, and you will see that in patients that you see, that they think because they have chronic back pain or chronic knee pain, well, it must be from osteoporosis, but they're not related at all. So in order for us to assess these patients for osteoporosis, we do their history, we do their physical exam, look at their medication list. Okay, look and see what they're taking medications for, and how those medications may in fact impact or increase our risk for osteoporosis. Okay? Look to see or find out if they've had a history of a fragility fracture. Again, fragility fracture is a fracture usually of the hip, of the back, of the femoral neck, maybe the wrist area, just from standing. I was standing and fell, or standing and walking and I fell, and not from a height. And then potentially labs, okay? Especially if someone has a T-score below 2.5, get some labs on these patients. I bet you their vitamin D level is pretty low. Time for a break. Based on the patient's history, personal history, family history, there might be additional labs. You don't need to, there's nothing on here you need to study. There's plenty of additional labs. For us to be able to identify if someone has osteoporosis versus osteopenia, we use the T-score or the Z-score. So which one do we normally use? The T-score. The T-score compares a person that is getting this imaging with a person the age of, I don't know, like 30, 35 years old, which is considered your the peak of your bone mass density, 20 to 35 or so. So it's going to compare a 60-year-old or a 65-year-old with a 35-year-old bones, and feels like it should be pretty comparable. The Z-score, we often use that more for secondary osteoporosis. And nowadays, the DEXA scans that I've seen, they have both the T-score and the Z-score on them, but we still really focus more in on that T-score. So who, in fact, gets or needs to get screened for osteoporosis? We use the DEXA tool to screen that DEXA radiology studies, and it's gonna be done in all women that are 65 years old. All women, 65 years old. If you're 65, it's on the list of things you gotta do. So you can drop off the pap smears, but you gotta pick up the osteoporosis screening, okay? If they're younger than 65 and they have risk factors, then they need to have a DEXA scan. Or if they have sustained a fragility fracture of the hip, spine, long neck, or something like that. So 65, so a healthy 65, I don't have any medical problems, don't have any risk factors, I'm 65, I need a DEXA scan regardless of how healthy I am. I am younger than 65, I'm 63, but I smoke, I'm very thin, and I take steroids all day long. Well, then I need DEXA scan, right? Even though I'm younger than 65. I fell, I'm 61, I broke my hip, when I was just walking and fell and broke my hip, I need a DEXA scan, okay? Perimenopausal, so that is before they've even gone through menopause. We're talking about in their late 40s, okay? These patients, if they have risk factors from the shattered family, if they have really low BMI, or they are on meds that are known to accelerate bone loss or cause osteoporosis, then these patients are oftentimes considered that they need a DEXA scan much earlier. So it may be someone that's 49 or 48, they may be getting a DEXA scan based on the risk factors that they have. If someone comes in and we have that report, we order that DEXA scan, we get the report back, and on that report we see T-score of -1 to 2.5 or above, then that is considered normal. They do not have evidence of osteopenia or osteoporosis. Osteopenia -1 to -2.5 is osteopenia, and then osteoporosis is greater than -2.5. So -2.5, -3, -9 up is going to be osteoporosis. So that's how we diagnose it. So we diagnose this with the DEXA score, that -2.5, okay? Doesn't matter where the site is that we see the -2.5. Remember when they do the DEXA score, they will mark, okay, this is the T-score at this site, at the hip, and this is the T-score at the vertebrae. So put that out there. Or it can be automatically diagnosed without a DEXA T-score in the setting of a fragility fracture. We want to talk to our patients how we can prevent this from happening, because we know the significant increase in morbidity and mortality that they fall and break their hip if they have a fragility fracture. So frequent weight-bearing exercises. So they don't need to be out there running, but they can walk, they can do their weight training as well. Decrease smoking or stop smoking altogether, decrease alcohol consumption, reduce fall risk. Many times it is recommended that these patients don't have throw rugs, or older patients don't have throw rugs in their home, because there's increased risk of them tripping over the throw rug and then falling and breaking something. The other thing that's often recommended is they space their furniture out in the house, so that if they were to feel lightheaded or dizzy, there's a piece of furniture here, and then there's a piece of furniture here, and there's one here. So they kind of space it out to reduce their risk of falls. Okay? DEXA scan testing, so bone mass density testing should be offered and should be recommended for those 65 and older without risk factors, and then maybe sooner than that for those with risk factors. Measure their height annually. We know as people get older, they have a reduction in height, sometimes up to a couple of inches in height. If we can identify that someone that's in their 50s for some reason is losing height already, then that might be an indication that they need DEXA scanning earlier as opposed to later. Okay? And then we need to talk to our patients about appropriate supplementation, using calcium, vitamin D. If we see young troopies in the emergency department, they come in and they have a stress fracture of some sort, or they have any fracture, whether it's stress or not, orthopedics automatically puts them on vitamin D. Doesn't matter if they're 20 years old or 40 years old, they're going to put them on vitamin D. They put them on vitamin D that they take 50,000 units once a week. So that can be done very early on. We don't have to wait till our 30s, but at a minimum, we'd like to have them start doing calcium supplementation in their 30s, about a gram a day. Greater than 51, we increase that to 1,200 milligrams a day. If they're postmenopausal, no history of fractures or no history or no increased fall risk, then we can do about vitamin D 600. But if they have a high risk or evidence of osteoporosis or history of osteoporosis, we do vitamin D 800. So it's not just the calcium, we want the vitamin D supplementation as well. And then medications. So we typically think about treating osteoporosis if we have that T-score less than negative 2.5, or they have a fragility fracture, or if they have osteopenia with risk factors. Look at the risk factors. So we can reduce reabsorption by giving them estrogen replacement if they're the appropriate candidate for estrogen replacement therapy. We can use a SERM, that helps prevent and treat. So again, we think about prevention and ultimately treatment. Bisphosphonates, we can do that prevention and treatment as well. The denosumab, that's also called Prolia. We can use that for treatment, so that's not used for prevention. It can be used if someone's diagnosed with osteoporosis. Calcitonin is considered second line, that can be used for treatment. Vitamin D and calcium, that's for prevention. And then we also can sometimes consider parathyroid hormone replacement to help stimulate bone inflammation, more of a second line treatment. But most of the time, we talk to our patients about biphosphonate use. That's the most common medication that we use for the treatment of osteoporosis. The problem with biphosphonates is that it causes pretty bad GI upsets. We do talk to our patients about not taking it on an empty stomach. Start taking it on an empty stomach. Make sure they remain upright for at least 30 minutes after taking it. So don't take it at bedtime just before you go to bed. One thing I have seen, although very, very rare, is some adverse effects. I have not seen osteonecrosis of the jaw, but I have seen atypical femur fracture. So I saw a lady that came into the emergency department. She was just walking around in her kitchen. She was on biphosphonate therapy. She was walking around her kitchen and went to turn to go to the sink and broke her femur. And it was from the biphosphonate therapy. So it sounds unreasonable, but it certainly can happen. And oftentimes it's bilateral. They will go to do something, like they'll go to step down and they break, and then they fall, and then they break again. So, or break the other leg. So bilateral femur fracture, that's bad. So they recommend not using biphosphonate therapy for greater than 5 years. If it needs to be used for greater than 5 years, a drug holiday. So that drug holiday at least a year, even up to 5 years, and then you can put the patient back on the biphosphonate. So no longer than 5 years, but if it has to be used, then we do that drug holiday by taking them off for a period of time. So first line is going to be the biphosphonate. The Fosamax is usually used, that's 70 milligrams once a week, or the Prolia can be used as a sub-Q. And now they even have medications that can be used once a year. Vitamin D deficiency, if that's identified on labs, and we wanted to do additional vitamin D supplementation as well. And then we already talked about calcium supplementation for both prevention and treatment of osteoporosis. That is it for our menopause and osteoporosis. Now, look how funny this is. How do you handle metronidazole? Carefully, because it's fragile. You guys get it? Fragile, same medicine. Oh, Lordy. TLOs and our ELOs. Okay, we have a question. Let me see here. LASIK. Oh, there you are. Okay, sir. What lab indicates menopause has occurred? B? Similar, but not the same.
C?
D?
C.
C? Yeah. C. Did you say C from the beginning?
No, I said B.
Okay.
Still got candy.
So increase FSH. And think about it that the ovaries are not working. So they're not going back to the pituitary and tell the pituitary to shut down FSH. Pituitary doesn't know that the ovaries aren't working well, so it's bombarding them because they're not getting that negative feedback back. They're shut down. So we have a significant increase in our FSH. All right, now what about Basuto? Okay, you've got a 59-year-old postmenopausal female. She's got vaginal dryness, dysuria, hot flashes, her day and night. She smokes a little, drinks a little, has hypertension, diabetes. You suggest hormone therapy. Maybe we should revisit that. But anyway, you suggest hormone therapy. And if you're going to give her hormone therapy of all these things, why are we giving her hormone therapy? Oh. D, vasomotor symptoms. Yes, here you go. So we would like her to be protected cardiovascular-wise. And we would like that, but that's not a reason to give hormone therapy. We would like to prevent colon cancer, still not a reason. Okay, the only time we give hormone therapy is vasomotor symptoms, at least based on what American College of Gynecology says. Okay. So the vaginal tissue, okay, again, remember vaginal tissue medial to the heart line. It's made of that non-keratinized epithelium, stratified squamous epithelium, and that means that it's more friable tissue, okay, more sensitive tissue, like we saw with the genital urinary symptoms of menopause. It is very estrogen sensitive and estrogen responsive. It produces glycogen. It has a secretory function. And glycogen that it produces is actually metabolized to lactic acid. And the benefit of that is that lactic acid makes the vaginal mucosa and the vagina itself more of an acidic environment. By being in an acidic environment, it helps protect the vaginal area and the vaginal mucosa and all the way up to the cervix and the uterus. It helps protect that from infection, from bacteria, from sexually transmitted infections. Okay? As women approach menopause, they don't have that protective, they don't have that glycogen production because the estrogen is decreasing. So they don't have that secretory function. So as people approach menopause or going through menopause and are postmenopausal, the pH goes up. And so they're going to lose that protection. But normally we think about the vaginal pH is around 4 to 4.5, so slightly acidic for that protective measure. There's a lot of different types of aerobes and anaerobes that make up the vaginal flora. But lactobacilli, that's going to be your prominent microorganism. And again, lactobacilli, they produce that lactic acid. And that helps protect from that STI. This is a picture of, what is this kind of cell? What's that? This epithelial cell, and we got our lactobacilli on there. And there's a lot of things that a patient can do to change the vaginal ecology or shift the makeup of that vaginal microflora. Antibiotics, especially long-term, are going to change the microflora. Oftentimes, patients that take antibiotics increase the risk of exposure or development of candida species, of yeast infection. So there'll be patients that come in and say, if you're going to give me an antibiotic, can you please give me something for yeast infection, because they're always getting yeast infection with antibiotics. Believe them, that is true. They're not just trying to get medication like fluconazole just to take it doesn't do anything special for them. So just give them that fluconazole if they're asking for it. Okay. Patients that douche frequently, also it changes the vaginal microflora. So we don't recommend frequent douching in the majority of patients. Unprotected, and of course the sperm will change the makeup of the normal microflora. And then any sort of foreign bodies, like tampons or insertion of any foreign body. When patients are on their menstrual cycle, we have a change in the hormones. We already talked about menopause and how that changes it. Pregnancy, increase in estrogen, so that's going to change the microflora. And then hormone contraceptives. So we talk about hormone contraceptives. A lot of patients are on hormone contraceptives. So we got to talk to them about the change in this microflora and how that may increase their risk for things like bacterial vaginosis or other vaginal infections. Okay? When we have something that offsets that vaginal flora, then we increase the risk of patients getting something called vaginitis. Vaginitis is vaginal inflammation because we no longer have that protection that we need to help reduce the risk of that inflammation or infection. The three main types of vaginitis are going to be bacterial vaginosis, which accounts for about 50% of causes of vaginitis, vulvovaginal candidiasis, which is a yeast infection, accounts for about 30%, and then trichomonas, which is sexually transmitted infection, accounts for about 20%. So here, what is this middle one? You guys learned that in lab? Candidiasis with all these pseudohyphae. This is a trichomonas, has a little tail on the back, the flagellum, and this is your bacterial. It's studied with Gardnerella species. So the most common cause of vaginal discharge is going to be bacterial vaginosis, and this is really an overgrowth of many species, but the primary overgrowth that we talk about, the species we talk about, is Gardnerella, from exposure to the Gardnerella. It is sexually transmitted. So it says can be sexually transmitted. That is what it's considered to be now. So what's really interesting about that statement is when I first trained, this was considered a sexually transmitted infection. So for years and years and years, you had to treat the patient and the partner. And then in 2015, they said, oh no, spontaneously, it's no longer sexually transmitted. You don't need to treat the partner, you only treat the patient. So then last year in March, they said, oh, it's sexually transmitted. You gotta go back to treating the patient and the partner. I'm like, oh my gosh. That's the thing with OBGYN, it changes all the time. Women's health, everything's always changing. So you may read literature from, not now, but once you actually have time to read literature, you may read literature from 2015 to 2024 that says it's not sexually transmitted, you don't need to treat the partner, but now in 2025 and 2026, you need to treat the partner. Okay? And oftentimes the discharge of these patients, this has not changed in 30 years, the discharge these patients complain of is this like homogeneous, kind of gray, milky, it's kind of like, this lecture is all about comparing bodily functions to food, but it's kind of like skim milk. So it's grayish, thinnish discharge that these patients complain of. And often, what's unique is they will often complain of this fishy odor, especially after intercourse. So when the patients come in and they're complaining of vaginal discharge, you want to ask them, what is the consistency of it, and is there any sort of odor? And or many times they'll just say, I don't know, it's so weird, it kind of smells really fishy. And I know I'm really clean down there, so I know it's not that. It's actually not that, it's actually the bacteria. Risk factors for bacterial vaginosis: multiple sexual partners or new sexual partners. Again, douching. We seem to see this more in African Americans than we do Caucasians or Asians. Smoking, and then IUD also increases the risk just because it changes the normal flora in the vagina. Reduced risk, condom use, of course, because again, sperm can change the normal microflora as well. How can we diagnose it? So if you're in an area that you can do labs, you can send either what's called a vaginosis vaginitis panel, or depending on the lab, it may be called a KOH wet lab panel. So you can send that off. If you're in an area where you don't have labs, or it's going to be a week before you get the lab back, you can actually diagnose this by clinically. So something called the AMSEL criteria. You need to have 3 of 4 criteria. We're looking for that discharge. We're looking for a change in the pH greater than 4.5. And then this whiff test. Yes, that's exactly what you think it is. And then clue cells on a wet prep, well, usually we don't have a microscope. When I trained, we had microscopes. We'd actually have to put the discharge on the slide. We have to go put it in the microscope, and we have to look at it ourselves. As a provider, you had to look at it because the lab techs in most of the clinics were not authorized to look at it. It was really kind of strange. So you got really good at looking at stuff under the microscope. So how do we know if the vaginal pH is greater than 4.5? Well, we can use this nitrazine paper. We use nitrazine paper for lots of things, but you'll take a swab of the vaginal discharge and you'll put that onto the nitrazine paper, and it'll turn blue if it's greater than 4.5. Is that acidotic or alkalotic? Alkalotic. We talk about more acidotic. All right. So greater than 4.5, doesn't matter. I'm not gonna ask you if it's more alkaline. But then the whiff test, like I said, it's exactly what you think it is. So you take this 10% potassium hydroxide, okay, 10% potassium hydroxide, you're taking some of that vaginal discharge, you put it on the slide, and then you're taking a drop of this 10% potassium hydroxide and you're putting it on the vaginal discharge. And when you do that, the amide reacts and creates this fishy odor. And the craziest thing, this is exactly what we had to do when I was primary care. Like, we totally had to do this. Because as much as you think the microscope was available, it was never available, it was always broke. So here we are in the office, putting it on there and going, like, oh, it was awful. It's like, isn't that, like, that's bad that you guys do that. Like, that's terrible, because we didn't have, you couldn't send the vaginosis without that pill off. So we did the AMSOS criteria. You guys think you had it rough. See, this, you probably will not be sniffing slides. So, and then, again, nowadays you ask the patient, do you have this odor, this no kind of fish? And it's important that we diagnose this, because if we don't, the consequences can be pretty significant. We increase the risk of other STIs or other infections. Because now, again, we're changing the vaginal flora, we don't have that protection. And also potentially increase something like HIV. Now, HIV doesn't affect the vaginal flora, it's more a systemic disease, but based on maybe the sexual partners that these patients are having, that may increase the risk of HIV. But gonorrhea, chlamydia, trichomonas, because we're having change in that vaginal flora. Tubovarian acids, PID, same exact thing, change in vaginal flora. Now that vaginal infection that is more distal has ascended. And it's coming around the cervix and maybe even ascended into the uterus, into the endometrium, and so it can cause endometritis. In patients that have had recent surgery, they make sure that they do swabs to make sure they do not have an active bacterial infection, because it can cause post-abortion sepsis or it can cause cellulitis after like something like that, after a hysterectomy or something. It can cause a vaginal cuff cellulitis. So these patients are checked first and swabbed first to make sure they don't have an active bacterial vaginosis. Okay. And then pregnancy, a big deal in pregnancy as well. Premature rupture of membranes, so babies coming out earlier than we expect potentially. Preterm delivery, babies definitely coming out earlier than we expect. Intra-amniotic infection, meaning mom is probably laboring, maybe her amniotic sac broke, but she had an active bacterial vaginosis, and now that bacteria is gone and is affecting the amniotic sac surrounding the baby. And then postpartum endometritis, the same thing we already said, it can ascend proximally and cause infection of endometrium. So that's why patients that are pregnant, they are screened at the beginning of pregnancy for bacterial vaginosis and other STIs. And then if they're high risk, they'll be screened again at the end. And if they're having any change in symptoms or new symptoms, they'll be screened as many times during the pregnancy, because they do not want these patients to have persistent bacterial vaginosis because of the risk. For pregnant patients with bacterial vaginosis, we have a couple of different treatments. We can use the metronidazole, 500 or 250. Now there's a question that says avoid a first trimester. If you talk to the pharmacy folks are not on board with American College of Gynecology. Pharmacy folks say you shouldn't be giving this in the first trimester. American College of Gynecology says it's fine. It's totally fine to give this in the first trimester. And so we will give this all the time now in the first trimester, no big deal. Okay, if we don't want to give Metro, we can give clindamycin. Now clindamycin is not without risk itself, risk for C. difficile with clindamycin. Or we can do Metro gel, it's an intravaginal gel for these patients. Okay? You can also do clindamycin 2% intravaginal cream for patients. So there's a whole host of the Metro, but really Metro gel, or Clinda oral, or Clinda gel, Clinda cream. And then for non-pregnant patients, guess what? Same treatment. So there's nothing new to memorize. We're still going to do Metro. We can do Metro gel, Metro orally, or we can do the clindamycin cream. Unfortunately, even if you catch this early on, you treat it appropriately, reoccurrence, occurs about 50% of the time, within 12 months. So certainly it could be that the patients, didn't have complete eradication of the Gardnerella species, or it could be, that they have a new partner, but most of the time, the failure of treatment. And most of the time that's what it is. It's usually not usually due to reinfection from a new partner. But certainly you want to get that history from them. So if you did not, which I assume that you probably did, but if you did not already check for gonorrhea, chlamydia, you need to do that now. You want to make sure. Oftentimes if I'm doing one swab, I'm doing the other swab. I'm doing both swabs at the same time. Okay? And nowadays it's pretty easy because American College of Gynecology does say that we can do self-swabs, or the patient can do self-swabs. So the patient can go to the bathroom and they can take the two swabs, gonorrhea, chlamydia swab, and the KOH wet prep swab, or vaginosis, vaginitis, and they go to the bathroom, they swab themselves, they put it in the container, and they bring the container back, and off it goes to the lab. I'll be honest with you, I still have a hard time with that, because I like to be able to see what's going on, I like to be able to see the type of discharge, but it's the way of the future. That's the way that we're going nowadays. So if you didn't do the GC chlamydia or the KOH wet prep, or the KOH which are candidiasis, and you want to make sure that you do that now. Male partner, we've got to treat the male partner. And I would treat the male partner from the beginning. If for some reason that didn't happen, we definitely need to treat the male partner now if there's evidence of reoccurrence. And then probiotics. Probiotics are considered okay for reoccurrence and actually been beneficial for reoccurrence, but not really been proven beneficial for the acute treatment of bacterial vaginosis. So if they come in with reoccurrence, you can treat them, but otherwise not for the acute. And then some patients, no matter how many times they've been treated and how aggressive they've been treated, you cannot eliminate the Gardnerella species from them. So it's really about suppressing their signs and symptoms. So sometimes we will put them on longer courses, or sometimes we'll talk to our patients and say, look, when you're having a flare, come and see me, otherwise you may consistently have this discharge. So if we have 3 or more confirmed cases of bacterial vaginosis in the last 12 months, meaning we've swabbed a patient that's come back positive for bacterial vaginosis, then we can consider different treatments. So first of all, if you did not get clindamycin, let's try that. So let's take them off the Metro, let's try the clindamycin regimen. We can do the clindamycin cream would be more effective. Otherwise, there's 2 other options. You can do the Metro regimen or the boric acid regimen. So what the Metro regimen is, we're doing the 500 twice a day for 7 days, so that's normal. And then we're doing Metro intravaginal gel, twice weekly, so PD is per vagina, twice weekly for 4 to 6 months. So we're going to start off doing that acute treatment, but we're going to add on to that is the Metro gel for an extended amount of time. Okay? The boric acid regimen, we're doing that Metro treatment, the acute treatment, the 500 twice a day for 7 days. At that same time, we're going to start them on these intravaginal boric acid capsules. And that's going to be done for 7 days, but you're going to continue that for 30 days. So again, we're starting Metro orally. At the same time, we're starting the intravaginal boric acid treatment, and that boric acid treatment is going to go for 30 days. Then they're going on the Metro intravaginally for 4 to 6 months. Okay, so we're adding that boric acid to that because it's supposed to change the vaginal pH and hopefully provide more protection for these patients. And I would definitely look over this because it is something you're going to need to know. That is it for today. Thank you.